may I call upon Dr. Sanjay Asrani? I don't think anyone in this hall probably does not know Dr. Sanjay Asrani. We've learned so much from him through so many years, and we'll continue to learn from him today too. Sanjay Asrani, please, sir.
Thank you, Sagarika. That is a glowing introduction. I don't think I deserve it that much, but thank you. I'm going to be talking about red disease, artifacts in OCT, and I think Dr. Mansberger set the stage perfectly for me by explaining how he uses the spectralis OCT in clinic. Now, why do we use the term red disease? Because red indicates alarm for us. Red indicates easy color to spot. That's why the Maasai tribes wear red when they are in the mountains, because you can spot them very easily. So red is always the indicator of danger, and that's why we use red in our normative databases. But then unfortunately, just because some measurements go into the red, it means like as if there is an abnormality, which is not necessarily the case. I'm going to share many examples for you, and it is in this order. That is myopia, machine errors, masqueraders like cancer-associated retinopathy, vascular events, other optic atrophies, neurological causes, age-related, congenital, and capture of OCT before loss of tissue thickness. So, when not to do an OCT in patients like this, where your circle scan is not large enough to go outside the area of the peripapillary atrophy. So then the measurements are not easily comparable to a normative database. You can see my mouse here. So it's not that you shouldn't do an OCT in this case, but don't rely on the normative database, but rely on the actual superotemporal and inferotemporal thickness. If that is normal, then very likely that this patient doesn't have glaucoma. The reason is that in myopia, all the nerve fiber layer tissue is more towards the fovea, more temporal. So if especially the temporal area is intact, then there is less likelihood of glaucoma. Of course, in such cases, using the macular thickness map is extremely useful to identify glaucoma or not. Then, of course, there is the machine errors, like what Dr. Mansberger already showed you. You can see here, it looks like that there is progression. But if you carefully look before you assume that there is progression, you realize that the software has missed the lower boundary of the nerve fiber layer. So therefore, it's a missegmentation. Therefore, it looks like it has gotten thin, but it hasn't really. Here is an example that is not easy to identify, because you got extreme thinning of the nerve fiber layer. You got severe loss of macular thickness. But if you look at the asymmetry plot, that is this left versus right and right versus left, the thickness difference between the two eyes is most away from the optic disc and in no arcuate pattern. This tells you that this may not be glaucoma. When it is not in an arcuate pattern in the asymmetry, this happens to be cancer-associated retinopathy, where the photoreceptors have died. Therefore, the retinal thickness is low. But that also affects the nerve fiber layer, surprisingly. Here is an example that we don't get to see very often. We see a patient whose nerve fiber layer has thinned out considerably in the superotemporal region. You can see the macular thickness has thinned out here. You see a new field defect. But is it glaucoma? Actually, no. This was because of a cotton wool spot that had been noted by another doctor 6 months ago. So that's why there has been a loss of tissue. Now, this location of the cotton wool spot is important, because if it is near the disc, you get all the changes that look like glaucoma. If it is away from the disc, it may not look exactly like glaucoma. So how do you identify that the changes that are looking exactly like glaucoma on OCT, are they due to cotton wool spots or are they due to glaucoma? Because most of our patients who have glaucoma also have hypertension, kidney disease, small cerebral vascular disease, and diabetes. All of these cause nerve fiber layer defects. So here is an example where you can see there is significant loss of nerve fiber layer. There is this arcuate loss here. But what you see is if you scroll through this retinal thickness, you realize that there is a spot out here in the periphery that there is a loss of the inner nuclear layer. If you see a focal spot of the inner nuclear layer loss, that is due to a vascular event. So you see these very wavy patterns in the middle of the retina, that's because of cotton wool spots. So if you see this, likelihood that what you're seeing is not glaucoma. Now here is a hemi-field loss, a hemi loss of the nerve fiber layer, a loss of the macular thickness, which is respecting the horizontal midline. Whenever you see a horizontal midline respecting disease, it is most likely a vascular event. Like this is a non-arteritic ischemic optic neuropathy. Then there is misinterpretation artifacts. You see the patient at one time, before and then after, and you realize there is a significant loss of macular thickness, significant loss of nerve fiber layer, but what you did not see is in between, there was a swelling of the nerve fiber layer, and that was again because of a vascular event. Now this is a patient who has a superior arcuate defect, a arcuate loss on the macular thickness, a focal loss here in the RNFL thickness, and you can see the loss of the nerve fiber layer thickness. So it looks exactly like glaucoma, but it turns out to be a branch retinal artery occlusion. You can see that on the this red-free image. Now, these are just some unusual examples that are just being presented to highlight the importance of looking at the entire picture. Remember one rule, that in glaucoma, especially in the early stages, you should not see any abnormality in the temporal region. So when you have red disease in the temporal region, when the cup is not total, it indicates it is possibly neurologic. And so even though this looks like an arcuate pattern loss, there is a loss of nerve fiber layer, but it shouldn't affect the temporal segment at this stage. And this turned out to be neurosyphilis. So think neurological if you see a temporal loss. Now what about this case? Are we dealing with severe glaucoma here? You can see the severe loss of nerve fiber layer in both eyes. But are you able to pick up a pattern? The pattern is right there. It's not very easy to identify what's going on when you look at the nerve fiber layer. But if you look at the macular thickness, you can see the vertical cut in the ganglion cell or the total macular thickness, so it's homonymous hemianopia. Or this one that tells you that a patient can have as many diseases as they like. This is a patient whose baseline nerve fiber layer thickness in the right eye seems to be getting thin, but thinning mainly in the temporal region. You can see that the difference between the baseline and the next macular thickness is loss again in the papillomacular bundle. And then you can see that the visual field is getting worse. This patient does have glaucoma, but the visual field is getting worse. How many of you are able to notice the pattern of bitemporal hemianopia in this? You can see there is a loss on the other side that's respecting the vertical midline, and on this side also. You don't get the textbook vertical midline picture always. And sure enough, it was a big pituitary tumor. How about this? You can see the nerve fiber layer thickness dropping tremendously, but that's because of vitreous traction that got released. As simple as that. And you can see it on a 3D image as well. Here is an example of a 42-year-old monocular patient who had lost the other eye due to an injury, who is on maximum medicines, comes in for a second opinion for normal tension glaucoma because he's been advised trabeculectomy. But wait, his field is normal. When you realize this, you see this pattern here. You see all these blood vessels coming out like the spokes of a wheel. This tells you that this is optic disc hypoplasia. This is optic nerve head hypoplasia. And the last couple of cases, whenever you see symmetry, symmetry is not typical of glaucoma. And you can see that there is symmetrical loss in macular thickness, symmetrical loss in nerve fiber layer and field, and this is segmental disc hypoplasia. And this is an example of ghost macula. This, you can see there are cystic spaces. So patients who have severe sudden loss of ganglion cells due to very high pressure, especially if they are young and the vitreous has not separated from the retina does not get to collapse. So the macular thickness appears to be normal, but it's not really normal. You can see these cysts. These are not CME. These are vertical cysts. That is because possibly because the vitreous is not allowing the retina to relax. And then catching OCT before thickness change. You can see that area, which pointed by the yellow, where there is already nerve fiber layer is hollow. Next visit, there is loss of thickness. So, in such a case, visual field may be affected already. And then you'll say, oh, but the OCT was normal, but actually it wasn't. So, thank you very much for your kind attention.
Thank you so much. That was a very enlightening talk.